Okay, vascular types. Inflammation and subsequent necrosis of blood vessels, leading to tissue ischemia or infarction of any organ system. It's basically it's what the inflammation and the necrosis following the inflammation of any organ system, which causes also the ischemia as well and infarction. Okay, how it's diagnosed? Clinical suspicion, suspect in case of unexplained multiple organ ischemia or systemic illness with no evidence of malignancy or infarction. Fevers will be constitutional symptoms such as fever, weight loss, anorexia, and fatigue. So we can suspect in any patient having, unexplained multiple organ ischemia or a systemic illness, which, with no evidence of malignancy or infection. Okay, and fever, weight loss, anorexia, and fatigue. Okay, and labs, non-specific anemia, increased WBC and CRP, and abnormal urine analysis, because it's the ischemia, so definitely everything will be deranged. Abnormal urine analysis, okay, and it's CRP if it will be increased WBC because there is some kind of body mechanism going on. And then anyway, investigation, biopsy of the tissue accessible, angiography if tissue is inaccessible. Okay, investigation is the biopsy, and treatment generally involves corticosteroid and or immunosuppressive agents. Okay, so features of small vessel vasculitis is palpable purpura, okay, vesicles, chronic urticaria, and superficial ulcers. Okay, we can see all these things in vasculitis. Palpable purpura, okay, fine, it will change the color, it will, it will be palpable, and vessels and itching and all, and ulcers, there might be irritations as well. Okay, so after that is the classification and the characteristics. Okay, non-ANCA associated, immune complex mediated, most common mechanism. Okay, anti-GBM, good pasture disease, antibodies targeting type 4 collagen in both glomerular basement membrane and alveoli, causing glomerulonephritis and pulmonary findings. Okay, in anti-GBM, we will get pulmonary findings and glomerulonephritis. It means that the lung and kidneys will be involved. We will get, findings of that. Okay, anti-CEA, vasculitis, specific autoimmune disorder with at least 6 months of urticaria. And these are the types, different types we can just read. I will just go to the sidebars. ANCA, cytoplasmic anti-neutrophil, cytoplasmic associated with anti-PR3. PANCA, perinuclear anti-neutrophil, cytoplasmic antibodies associated with multiple antigens. Example, myeloperoxidase, lactoferrin, elastase. Of these all antibodies to myeloperoxidase have been associated with development of vasculitis. Okay, fine. What is associated with the development of vasculitis is antibodies to myeloperoxidase, which are perinuclear anti-neutrophil cytoplasmic antibodies. Okay. EGPA triad. EGPA triad is formerly known as Church-Strauss syndrome. 50% in 50% of cases we can see ANCA positive. Okay, allergic rhinitis and asthma, eosinophilic infiltrate disease. Okay, fine. Eosinophilic is possible because there is allergies. Systemic vasculitis, often mononeuritis multiplex, peripheral neuropathy, and peripheral eosinophilia. Okay, fine. In system, we will see mononeuritis, peripheral eosinophilia. Okay. Features of medium vessel vasculitis. Okay, I will just show the pictures as well, so we can see how it is presented. The video verticularis. Okay. Okay, so it will be presented like this. This is medium cell vasculitis. Libido reticularis, which is known as resembles a lace or net in appearance and is a cyanotic or bluish discoloration with which surrounds a pale central skin area. There is a pale area we can see, and it's a lace-like pattern, and it's either cyanotic or bluish discoloration. Okay, a libido reticularis, erythema nodosum. So I will just do that also. Okay, it will be seen like this, something. These kind of ulcers. Erythema nodosum. And they are usually self-limited, and rash, and it's symptomatic also. Treatment is symptomatic. And Raynaud's phenomena we all know, and nodules and digital infarcts and ulcers. So these are the features of medium vessel vasculitis. If anyone wants to know any okay, so okay, someone is asking that what is Raynaud's phenomenon. So it's a condition in which some areas of the body feel numb and cool in certain circumstances. And smaller arteries that supply blood to the skin constrict excessively in response to cold, limiting blood supply to the affected area. And the finger, the toes, ear, and the tip of the nose are commonly involved, and they feel numb and cool in response to cold temperatures or stress. So this is the Raynaud's phenomenon. Okay, then classification of vasculitis and characteristic features. Large vessels, GCA, temporal arthritis, okay, inflammation predominantly of the aorta and its branches. Age, it's greater than 50, and it's more common in females. Temporal headaches will be there, jaw claudication will be there, scalp tenderness will be there, and vision loss. Okay, fine. It's temporal, so temporal arteries involved, and temporal headache will be there. Jaw, it will be jaw claudication, scalp tenderness will be there, and vision loss. And this one is not so clear. Just a second, everyone. Okay, the other is Takayasu arthritis, pulseless, pulseless disease, unequal peripheral pulses, chronic inflammation, most often the aorta and its branches. Okay, in temporal also aorta and its branches, and ages is 50, and it's more common in females. And Takayasu is a pulseless disease and unequal peripheral pulses. Like both the body, it will be peripheral pulses will be not equal, and it's the chronic inflammation most of common, most often the aorta and its branches, most common in young adults of Asian descent, ages 10 to 40. Again, female is more common, and risk of aortic aneurysm is there. Okay, in the temporal, it's age 50, female is common. And in Takayasu, it's again 10 to 40, but a female is common, and there is a risk of aortic aneurysm as well. And other are Again, it's not clear. Okay, Behcet's disease, vasculitis, pseudovasculitis is there, and wait. Okay, there is this Berger's disease, Behcet's disease, and vasculitis, which is I cannot read the word, but it's pseudovasculitis. Berger's disease is inflammation and clotting of small and medium-sized arteries and veins of distal extremities. May lead to distal claudication and gangrene. The most important etiologic factor is cigarette smoking. Most common in young Asians, and in this, males are more predominant. Yes, males are more predominant. And so, okay, fine. In this, it is small and medium, both arteries are involved, and the veins of distal extremities are involved as well. And it's more common in smokers and in males. Okay, and the Behcet disease, multi-system disorder presenting with ocular involvement. Okay, and recurrent oral and genital ulceration, venous thrombosis, skin and joint involvement, most common in Mediterranean and Asian population. Average year age is 30 years, and again, it's more common in males. Okay, and Behcet disease is more common in males, Asian and Mediterranean population, and they will be having oral and genital ulceration as well as involvement of eye. And then it's pseudo vasculitis, which is the cholesterol emboli, and atrial myoma, subacute bacterial endocarditis, and in the antiphospholipid, this APS also. Can anyone just tell me what is APS? Is this antiphospholipid or what? Anyone? Yes, it's antiphospholipid syndrome. Okay, good. Wait, I will just open the chat in the side also, so I can read whatever you are sending, everyone. Okay, so here is here they're just showing how these are the large arteries. This is the medium one. This is small, and this is capillaries and vessels. And the large one we can say, okay, it's GCA and Takayasu arthritis. Medium is PAN and Kawasaki disease. What is PAN? And you can anyone can tell me?
Arthritis nodosa.
Yes. And GPA is gluno granulomatosis with polyangiitis, formerly known as Wegener's disease. Okay, and the small one is causing ANCA associated vasculitis, GPA, MPA, and EGPA. I think so. We just have to write it from there what it stands for. And non-NCA. Okay, this is the large one. This is the medium and small. The large one is in water. This one, the medium. Okay. Now, small vessel, no, non-ANCA associated vasculitis, cutaneous. It is divided into drug-induced, serum sickness reaction, vasculitis associated with other underlying primary diseases such as infections, malignancy, and hematologic or solid tumors are more. Etiology and pathophysiology is cutaneous vasculitis following drug exposure, such as allopurinol, gold, sulfonamides, penicillin, and phenytoin, viral and bacterial infection. Idiopathic causes, small vessels involved post-capillary venules most frequently. Okay. Post-capillary venules are most commonly involved. Usually causes a leucoclastic vasculitis debris from neutrophils around vessels. Okay. Sometimes due to cryoglobulin, which precipitate in cold temperatures. Okay. Again, palpable purpura, usually lower extremities with or without vesicles and ulceration, urticaria, muscles, papules, bullae, subcutaneous nodules. Renal or joint involvement may occur, especially in children. Okay, fine. Especially in children, there will be renal and joint involvement as well. And otherwise, it will be cold extremities, ulcerations and vessels and urticaria and papules. And usually, palpable purpura is always seen in the lower extremities. Investigation is vascular involvement, both arterial and venule, established by skin biopsy. Okay, we will do the skin biopsy. Treatment is stop possible offending drug, treat underlying primary disease, NSAIDs, and low-dose corticosteroid. Immunosuppressive agents in resistant cases. It's usually self-limiting as well. And small vessel ANCA associated vasculitis. Okay, non-ANCA, and this is ANCA. Okay, can anyone tell me that, okay, fine, the non-ANCA associated, are they having any name? It's small arteries are involved, proximal and palpable purpura. We saw in here as well. Okay, granulomatosis with polyangiitis. Granulomatous inflammation of vessels that may affect the upper airways, rhinitis and sinusitis, lungs, pulmonary infiltrates, nodules, infiltrates caused by pulmonary hemorrhage, and kidneys, glomerulonephritis, and renal failure. Okay, in a small vessel ANCA, we will see pulmonary nodules, infiltrates, pulmonary hemorrhage as well, glomerulonephritis, and renal failure. Highly associated with CANCA by indirect immunofluorescence and PR3 ANCA by ELISA. However, changes in ANCA levels do not predict remission or relapse. Okay, do not predict remission or relapse. Incidence is 2 to 3 in 1 lakh, more common in northern latitudes. Okay, clinical features of GPA: necrotizing glomerulomatosis, vasculitis of lower and upper respiratory tract, focal segmental glomerulonephritis. And this is the classification of GPA. It's the nasal involvement, cartilaginous involvement, and the hearing loss. And these are the scores given. If there is a nasal involvement, it will be +3. If it is a cartilaginous involvement, then it's +2. And hearing loss is score 1. So, and laboratory findings or imaging of biopsy criteria is CANCA or NT-PRC is positive, then it's 5. Pulmonary nodules, cavitation, chest imaging, then it's 2. Granuloma and granulomatous inflammation, giant cell on biopsy, giant cell on the biopsy, then it's again 2. Inflammation, effusion of nasal and paranasal sinuses, mastoiditis or imaging, it's 1. PNCA or anti-MPO positive, then 1. Blood eosinophil count, 1 to 10 raised to power. I cannot read it. I think so. It's 9 per liter and it's 4. And posse immune glomerulonephritis on biopsy, it's 1. Etiology and pathophysiology. Pathogenesis depends on genetic susceptibility and environmental triggers. That's infection. Dysregulated immune response due to loss of B and T cell tolerance. Acute vascular injury mediated by neutrophils and monocytes. The presentation is systemic. It's malaise, fever, weakness, weight loss, head, eyes, ear, nose, and throat. Head, eyes, ear, nose, and throat. The short form mnemonic is HEAN. Sinusitis, rhinitis, nasal crusting or bloody nasal discharge, nasoseptal perforation, saddle nose deformity. Proptosis due to inflammation, vasculitis involving extraocular muscles. Okay, in this also extraocular muscles will be involved. Granulomatous bulbular space occupying lesions will also be there, or direct extension of masses from the upper respiratory tract. Hearing loss due to involvement of cranial nerve aids. Pulmonary cuff, hemophysis, granulomatous upper respiratory tract masses, tracheal and bronchial stenosis, renal, hematuria, proteinuria, elevated CR, glomerulonephritis, creatinine and glomerulonephritis, joint, skin, eye complaints, just iritis and vasculitic neuropathy. Investigation, blood work, anemia, normal mean corpuscular volume, MCV, increased WBC, increased CR, increased CRP, elevated platelet count, ANCA and PR3 greater than MPO. Urine analysis, proteinuria, hematuria, and RBC casts. Chest X-ray or CT, pneumonitis, lung nodules, infiltration, and cavity lesions. Biopsy for confirmation of disease. Skin, renal, lung, skin and renal segmental necrotizing glomerulonephritis. In lung, we will see vasculitis or necrosis. CRP may be used to monitor the response to treatment in some patients. Okay, CRP is usually monitored to see the response of the treatment. So it is the blood work and everything as it's involving everything. So it will be, WBC will be raised, platelet count will be raised, ANCA will be seen, PR3 and pure urinous proteinuria because kidneys involved. Checks X-ray, either it's nodules or infiltrates, biopsy, necrotizing glomerulonephritis, and the lung it's vasculitis and CRP in response to to check the response of the treatment. Treatment, severe life or organ-threatening disease, induction therapy, that is IV glucocorticoids, either IV or oral cyclophosphamide or rituximab, glucocorticoid, methylprednisolone, followed by prednisolone, and then we will gradually taper it. Okay, methylprednisolone, and which is followed by prednisone, and then after 2 to 4 weeks, and then we will gradually decrease the dose and then taper it down. Okay, cyclophosphamide, and okay, dose adjustment, adjust for older age and renal failure. Rituximab and maintenance therapy is initiated once remissions is achieved. Consider corticosteroid sparing agents such as rituximab, or for maintenance, azathioprine, methotrexate, and mycophenolate are reasonable alternatives. Okay, these are the alternatives. Plasma exchange can be treatment for patients with severe organ involvement, renal failure, pulmonary hemorrhage, and responding to conventional induction treatment. Non-organ threatening disease, we will give prednisolone and or azathioprine. And screening and prophylaxis, all patients should receive screening and prophylaxis for corticosteroid-induced osteoporosis. PUD prevention and pneumocystis GROVC prophylaxis, trimethoprim sulfomethazole. Okay, this is the prophylactic treatment which we will give for to all the patients. And all the patients should receive, we should screen all the patients and give prophylaxis for corticosteroid osteoporosis, peptic ulcer disease prevention. Also, we will give something when we are giving this to patients, and prophylaxis of this is trimethoprim sulfamethasone. Okay, so this one is also important in while we are treating what small vessel ANCA associated vasculitis, because we are giving so much medications. Steroids cause osteoporosis. Okay, so Rida, do you want to read this medium vessels? Anyone wants to read this medium vessel? Okay, medium vessel vasculitis is polyarteritis nodosa. It's the systemic necrotizing vasculitis of medium-sized vessels defined as visceral arteries and their branches. They are AMCA negative, classically lung sparing, means lung is not involved in this systemic necrotizing vasculitis of medium-sized vessels. Okay, 5 to 10% is associated with hepatitis B positivity. Okay, 5 to 10% might be hepatitis B positive. Incidence is 0.7% in 1 lakh. Affected individuals are 40 to 60 years, and male and female ratio is, again, it's more common in males, and it's 2 to 1 male to female ratio. And the classification criteria of polyarteritis nodosa is weight loss, weakness, leg tenderness, libido reticularis, neuropathy, testicular pain or tenderness, elevated creatinine or bun, hepatitis B positive, arteriographic abnormality, and biopsy of artery. And creatinine is usually blood urea nitrogen is greater than 14.3 millimole, and creatinine is greater than 130 millimole for the diagnostic of PAN. And can anyone tell me what is DBP? Anyone? Diastolic blood pressure. Okay, your diastolic blood pressure would be greater than 90 mmHg. It's, yes, it's diastolic BP. Okay, and creatinine and urea nitrogen will be your greater than 14, and creatinine will be greater than 130. So these are the criteria: weight loss, weakness, libido reticularis, neuropathy, testicular pain or tenderness, diastolic blood pressure greater than 90, elevated creatinine or urine nitrogen, hepatitis B positive, uh, arteriographic abnormality means aneurysms will be there, or biopsy of the artery which shows the presence of granulocytes and or mononuclear leukocytes in the artery wall. Granulocytes and or mononuclear leukocytes in the artery wall. Okay, etiology is focal pan neural necrotizing vasculitis, small and medium-sized arteries, thrombosis, aneurysms, or dilation lesions site may occur. Dilation at lesion site may occur. Okay, thrombosis, aneurysms, or dilation can occur on the site. Okay, heat lesions show perforation of fibrous tissue and endothelial cells that may lead to luminal occlusion. Okay, that may lead to heat lesion, may show proliferation of fibrous tissue, proliferation of fibrous tissues and endothelial cells. Okay, which can cause luminal occlusion. And the presentation is systemic fatigue, weight loss, weakness, fever, arthralgia, libido reticularis, nodules, purpura eruptions, renal insufficiency, which leads to hypertension, and moroneuropathy multiplex in both motor and sensory nerves, abdominal pain, and mesenteric uh, arteritis. Investigation: blood work, CBC, CRP, creatinine, urine nitrogen, urine analysis, liver enzymes, PA and CA, hepatitis B and C serology, imaging, CT, MRI, angiography shows beading appearance of blood vessels. Okay, fine. It's something very important. Beading appearance on of blood vessels will be seen on imaging. Biopsy, it's highly vascular tissues, liver, not recommended due to risk of aneurysm rupture. Okay. Biopsy of affected organ, that is skin or nerve. Biopsy of highly vascular tissues, that is liver, not recommended due to the risk of aneurysm rupture. Okay. Treatment is with no major manifestations, glucocorticoids, and with or without azathioprine, and with major organ manifestation, we will do induction therapy with high dose glucocorticoids. Okay, with low dose, it's with no organ manifestation, it's glucocorticoids with or without azathioprine. And with organ manifestation, it will be high dose glucocorticoids plus cyclophosphamide for 3 to 6 months, followed by maintenance therapy with low dose prednisone, either either azathioprine, methotrexate, or leftomide. Treatment should be a minimum of 18 months. Okay, we have to treat it for 18 months. Okay, hepatitis. Yes, we can remember it like this. Polyneurosis is period appearance on imaging. And biopsy will not do on the the liver or highly vascular tissue because due to risk of rupture. Moreover, who can tell me that I just forgot. Uh, okay, I will just go. Okay, fine. Minimum of 18 months treatment we have to give here. There was a question in my mind and I just, absolutely I just forgot. Okay, hepatitis B virus associated vasculitis, we will give prednisone, with or without methylprednisolone. And after corticosteroid therapy, treat with plasma exchange and antiviral therapy. Okay, and before there was a uh, question in my mind. I think so. We just read about one more treatment which we have to. Yes, we were. Yes, CRP. We will monitoring for the treatment prognosis. So, which disease was that? In which we were, monitoring the CRP to see the prognosis of the treatment. Anyone? Yes. It was GPA, small vessel ANCA associated vasculitis, in which we were, we are going to monitor CRP to see the response to treatment in some patients. Yes. And in this, yes, hepatitis B is with pan polyarteritis nodosa. And in this small vessel ANCA vasculitis, there is no hepatitis. It is just CRP and hepatitis C mixed with we can see, when they are doing this in media polyarteritis nodosa, we are also doing hepatitis B and C, both serology we are doing. So in while we going to investigate for pan, we will order both the tests, both B and C, along with liver function, liver function test and this this renal function test. It's a small vessel vasculitis too. This pan, yes. No, pan is the medium vessel vasculitis. And medium-sized vessels and visceral arteries and their branches are involved. No, pan, if you're saying pan is a small vessel, so it's the medium vessel vasculitis, and it's mentioned over here also. It's a medium vessel. Okay, we will just revise one more time and then we will move forward. So what we have read so far is that yeah, and like we have just read that, okay, fine, in polyarteritis nodosa also, in pan also we are having ocular involvement, and whereas in this Behçet's disease, this which is here it is, yes, there is also ocular involvement. Okay, then what we have read, okay, a small vessel, there are two types. One is non-ANCA associated and one is ANCA associated. So non-ANCA associated, usually, drug-induced serum sickness reaction, vasculitis because of infections, malignancy. And, it's because of exposure of the drugs. It can be infection and it can be idiopathic. Okay. And Okay, and sometimes cryoglobulins which precipitate in cold temperatures also, and in that we will the presentation will be palpebral purpura, ulceration, urticaria, and renal involvement will be there, and renal involvement and the joint involvement will more common will be only in children. Okay, rest it will be palpebral purpura, papules, macules, and bullae. And treatment we will just give the because it's drugs involved, we will stop the drugs, NSAIDs, and low dose corticosteroids, and most of the cases it's self-limiting. It's usually self-limiting. Okay, it might go on. Okay, and then it is small vessel ANCA, and what's there, it's the involvement, there is a big involvement of every other system, such as we can see over here. It is head, eyes, ears, nose, throat, and then lungs as well. Then kidneys also, and other eyes and joints. Everything is involved in this, and it also causes hearing loss because of cranial nerve 8 involvement. Okay, and it's also cause saddle nose deformity. Proptosis will also be there, and upper respiratory tract, extensions and masses from the respiratory tract, leading to this proptosis. And pulmonary, we can see hemophysis, stenosis, and renal hematuria and all. And here the blood, we will do the blood workup. Then urine analysis, this urine analysis we will see because kidneys involved. This then imaging, chest X-ray and CT scan. Then biopsy is for the confirmation of the disease. Biopsy is the confirm the disease. It's the biopsy, and in biopsy we will see this segmental necrotizing glomerulonephritis and lung vasculitis and necrosis, and CRP we will to monitor the treatment in some patients, and the treatment is glucocorticoids with a or cyclophosphamide and cyclophosphamide, and then rituximab, and the maintenance therapy is uh, rituximab for maintenance, and azathioprine, methotrexate, and mycophenolate are reasonable alternatives to what rituximab, and plasma exchange. And this is for severe life-threatening organ disease. We are giving what glucocorticoids, then rituximab, and maintenance therapy is also done with this. But if it's not suiting someone, then we will change the drugs, and then it is plasma exchange. And after that, if there is non-organ, then it's only prednisolone or azathioprine. And screening and prophylaxis is very important in all the patients because it can cause corticosteroid induced osteoporosis, uh, ulcer, prevention also, gastric ulcer, PUD also is there, pelvic ulcer, peptic ulcer, and then for this, we are going to pneumocystis, pneumocystis. We are giving trimethoprim sulfametazole, and then the medium which we have learned is PAN, which is polyarthritis nodosa, and here it's A and C are negative. In 5 to 10%, hepatitis B will be positive. Weight loss, libido reticularis, neuropathy, testicular tenderness, diastolic greater than 90, elevated creatinine and urea nitrogen, hepatitis B positive, abnormality of arteriographic abnormality, which is aneurysms, and biopsy. And it's caused because of necrotizing vasculitis, thrombosis, endothelial cells, from the fibrous tissue they proliferate, and then which causes the luminal occlusion. Systemic is fatigue, weight loss, arthralgia, renal involvement insufficiency है, which leading to hypertension, abdominal pain, purpura eruptions. Investigations involved this blood, this, and in this also we will do the liver function test, CBC, the kidney function test, and then hepatitis and B serology. We will do both, and imaging we will do CT and MRI, and we will see the bleeding appearance, and biopsy we will do of the skin and nerve. We can, but we will avoid in highly vascular tissues because of what the risk of aneurysm, rupture of aneurysm, and the treatment is glucocorticoids with or without azathioprine, and if it's multi-organ manifestation, then it's high dose glucocorticoids with cyclophosphamide, and maintenance therapy is usually with low dose prednisolone and either azathioprine, methotrexate, or leflunomide. And hepatitis B or virus associated vasculitis, we will give prednisolone with or without methylprednisolone, prednisone with methylprednisolone. And after corticosteroid therapy, we will treat with plasma exchange and antiviral. If it, if there is hepatitis B also, then we will give this antiviral as well. But after treating, initially we would start with prednisolone, this, and after corticosteroid therapy, plasma therapy with antiviral. Now it is large vessel vasculitis. Just a sec. Okay, giant cell arteritis or temporal arteritis. The classification is age, it's greater or equal to 50. I cannot read. If anyone can tell me what is that? New, what is that? Often temporal. New headaches, I think so. And temporal artery abnormality, elevated ESR, and abnormal artery biopsy. Okay, ESR will be greater than 50, and temporal artery abnormality will be tenderness, will be there, decreased pulsation, not due to arteriosclerosis. Okay, abnormal artery biopsy, the biopsy will show what? Mononuclear cell infiltration or granulomatous inflammation, usually with multi-nucleated giant cells. Okay, we will see multi-nucleated giant cells on the biopsy. Okay, above we just read on biopsy, there you were seeing some giant cells and some. Can anyone tell me what was that? Where were we seeing that? Anyone? Anyone? Yeah, we're just, it was, I think so. The biopsy here, it was showing that we will see uh, vascular involvement in skin biopsy. It was here. We were seeing some abnormal thing. It was bleed experience in pants. And there was something also very abnormal in the biopsies of it. Vasculitis, necrotizing glomerulonephritis. Okay. Okay, I will just see it again. Okay, in this we will see, multinucleated giant cells will be seen. Okay, and it's most common in North America. Patients are usually greater than 50 years old. Peak incidence is 70 to 80 years, and it's more common in females. North to south gradient predominance in Northern Europe and US, affect extracranial arteries. And clinical presentation, okay, fine, here what's written. Okay, GCA criteria. As presence of 3 or more criteria yields sensitivity of 94% and specificity of 91%. If there is 3 or more, then it's more, 94% it's sensitive, and the specific it is 91%. Okay, 3 or more. Okay, new onset temporal with or without headache, I think so. HA, with or without scalp tenderness, overlying temporal artery. Overlying temporal artery. Okay, sudden painless loss of vision and or diplopia due to narrowing of ophthalmic or posterior ciliary arteries. Okay, can affect both. Due to narrowing of the ophthalmic or posterior ciliary arteries. Okay. Tongue and jaw claudication, pain in muscles of mastication on prolonged chewing. Okay. Proximal pain and stiffness, constitutional symptoms, elevated ESR. Okay. Proximal pain and stiffness and elevated ESR occurs in 30% of the patients Aortic arch syndrome, which is involvement of subclavian and brachial branches of aorta, resulting in pulseless disease. Aortic aneurysm with or without rupture are the late complications. Constitutional symptoms, example, fear of unknown origin in patients greater than 65, shoulder or pelvic girdle pain and stiffness will be there. And diagnosis is made by clinical suspicion, increased EHR, increased CRP, and colored Doppler ultrasound of temporal with or without axillary artery. And yeah, we will see what we will see there. We will see a hollow sign. An MRI consider temporal artery biopsy also. So the investigation is increased as ESR, increased CRP, Doppler ultrasound of temporal with or without axillary arteries, and we will see this hollow sign and MRI and consider temporal artery biopsy also, halo sign on ultrasound. Halo sign temporal. Fine. It will be something like this. Halo sign of common superficial temporal artery. Typical halo sign. So, and one is the right temporal artery. Okay. And wait a minute, someone is asking what is. Okay, someone is saying what is PMR? PMR is a polymyalgia rheumatica, which is a condition cause pain and stiffness and inflammation of muscles around the shoulder, neck, and hips. It's written pain proximal, a pain and stiffness and elevated ESR, PMR, polymyalgia rheumatica. It's pain and stiffness and inflammation of the muscles. Okay, and investigation is hello sign of point treatment is we will immediately start prednisone and then taper prednisone by this, okay, as symptoms resolve, highly effective in treatment and prevention of blindness and other vascular complications. Okay, whenever we suspect, we will initially start, if we just, prednisone. If we will delay the treatment, then, it can lead to blindness or any vascular complication. Consider low dose ASA to help decrease visual loss. Low dose ASA. Anyone have any idea what is ASA? Anyone? It's aspirin.
Yes, aspirin, yes. No, good.
So low dose aspirin to, okay. Yeah. Okay. To decrease the visual loss, if presenting with visual loss at diagnosis, methylprednisolone followed by high dose prednisone. Okay. Initially, if you are suspecting, we will just give prednisone and we will give as quick as possible to prevent the blindness and the vascular complications. But if someone is already presenting with, this vision loss, then we will start with methylprednisolone, and which will be followed by, this high dose of prednisone. Okay. Tocilizumab and this IL-6 inhibitor, receptor monoclonal antibody has also been used in combination with glucocorticoids to treat this new or relapsing. Okay, fine. We can treat this with this also. But we have to start this, but we can treat with this also. Prognosis: increased risk of thoracic aortic aneurysm and aortic dissection. Yearly chest X-ray with or without abdominal ultrasound as screening. Okay, fine. Yearly chest X-ray and abdominal ultrasound is required as screening to just see. Okay. So we will stop here and we will acetyl salicylic acid. Okay. So we will stop this here and we will start the MCQs. We will just do 3 or 4 before the meeting end, till the meeting end. Okay, a 68